Carolyn Vicini is going to come up and show you, just do a little demo of it while everyone's settling down. Hello. Anybody? So as Susan mentioned, I am from Oncolink. So, okay. Oncolink is a cancer information website that is based out of Penn, and we were the first cancer information website on the internet, started in 1994 by Penn radiation oncologist who just thought the internet was kind of cool and a great way to disseminate information, so he started building this website, unbeknownst to the people at Penn. It's kind of funny. You go this way? There we go. Yeah, it's working. It's a little slow. So the content on our site is written usually by people from Penn, doctors, nurses, social workers, dietitians, people that kind of work with patients every day and they know what people want to know. It's free. There's no registration. You don't have to log on or anything like that. Information is written at all levels, from the novice person who doesn't know anything about cancer all the way up to stuff for physicians and nurses. And nothing is segregated, so you as the reader can delve as deep as you would like to go. So I'm just going to point out a few things that you might find useful. This is the home page. We're really excited that we are hard at work on a redesign, so this is going to be all new and streamlined in about a month. Very exciting. So look for that. And a couple things I'll point out on the screen. If you're looking for information about a type of cancer or treatment up here, and the support tab has things like nutritional information, different side effect management tips. So Oncopilot, maybe not the best resource for this group, but maybe someone in your family. Whenever someone in my family gets a cancer diagnosis, they get a book from me, which I'm sure they love, but I bring them a 3-ring binder with all kinds of blank pages on it so they can track appointments, track doctor's information, and keep it all together in one binder. So we made those forms into something you can download through this section on the website and build your own binder. The care plan is meant for people who have had a cancer diagnosis and finished treatment. This allows them to go in and learn about long-term effects of cancer treatment, healthy living after cancer, different follow-up recommendations for their type of cancer, and sort of how to transition to life as a survivor. And then lastly, the piece that might be of interest to this group is a program called What's My Risk? It was really created for people who just want to know what's their risk of cancer. So it covers all types of cancer, not just breast and ovarian. And it asks you a detailed questionnaire about your lifestyle, habits, all different things about your medical and social history. And then from that, it gives you a profile that talks to you about what the cancers you are at risk for and what are the risk factors that are putting you at risk. And most importantly, what can you do about those? So give you some resources, tips, and tools to, sort of take that this time when you want to make a healthy lifestyle change and help you make it. So give you the resources to do so. The only other thing I will tell you is that we are having some web chats this afternoon. 11:45 is for gynecologic cancers and 1:15 for breast cancers. And a lot of the experts from the conferences today are participating. So if anyone has questions they want to have answered by the panel, stop by and see us in the room next door and tell us what your question is, and we'll have them answer it. And that's it. Thanks a lot. Great, thank you very much. The one caveat I'll give is that this is pretty general risk information, so it can be really useful, about weight and smoking and things like that. For people with a known BRCA1 or 2 mutation, it's not delving that deep. So, but still, it can be a really useful site, and the care plans and everything can be very useful. All right, so next we're actually going to move on to some of the more psychosocial issues. And Jill Stauffer, who's one of the genetic counselors who has been at Penn since 1997,
4. Oh my goodness. Sorry. So Jill has been at Penn since the year BRCA1 was cloned. So there you go. So it gives you an idea. So she's really, but in that same context, Jill has actually been a leader in the field all of these years and has really provided a lot of insight. So Jill is going to go through some of the issues about family communication.
Been at Penn all these years, but I certainly haven't grown, at least not in terms of my height. I've grown in other ways. I want to thank you all for being here. My role today is to talk about talking to your family. Talking to the family about risk is not always the easiest thing, and we know that a genetic evaluation is a family evaluation. And what do I mean about that? So here is a beautiful family. A mom here with breast cancer, and what is she thinking? One of the things that we all think about when we're diagnosed with something significant is, what does it mean for my family? And in the case of breast cancer or ovarian cancer, what does it mean for my daughters? And we know that in cases where there's known or suspected genetic risk, that this really is a family issue. And it's a little bit unique to other medical conditions where, your high blood pressure may not be of any relevance to anyone else in the family. But this really is. And I'm going to talk a lot about how we can move this information into the family in an effective way and how to deal with some of the stresses and challenges that this can bring to a family. So I say sharing family history is a legacy that keeps on giving. When we know more about the family history, and in this case I'm talking about the family history of cancer, it can lead to significant changes in what people do. It can lead to changes in screening, as you heard Dr. Domchek talk about. It can lead to sometimes the diagnosis of a particular hereditary cancer condition. When that's possible, it gives us very important information about what to expect. What are maybe some other cancers that people are at risk for? What are some of the things we can do to change those risks? What are some of the things we can do to help people by knowing that? So it leads sometimes to suggestions for genetic testing for a particular gene that might explain what's going on. And it can offer the family potentially life-saving interventions. So family history is something that is important to share, and it's not always easy. A cancer diagnosis in some cases is something that can feel very private. There's things going on that you don't necessarily want to talk to everyone about, and that's okay. But keeping the fact that you've had cancer private to yourself and not sharing it with the family can sometimes thwart some of these very important opportunities. So what are the types of things that are important to share? Well, if a family can recognize the specific types of cancer, so where did the cancer begin? Is it a ovarian cancer? Is it a uterine cancer? Is it a cervical? Is it breast cancer? What is the specific type? And about how old are the people in the family when they developed it? And it doesn't have to be exact dates or exact ages, but some sense of how old was Aunt Millie when she got that cancer? Does anyone know? And the more you know about the family history, the more helpful we can be in suggesting some of these things, like particular screening recommendations, like, is this a family that we can make a diagnosis of a hereditary cancer condition for? And it's important to know that when you're sharing family history information, either about yourself or when you're asking people about their own family history, you're asking people about their own diagnoses, that it's not necessary that you share every detail. You don't need to share every kind of thing that's gone on when you were diagnosed. A lot of people aren't comfortable with that. It's okay, and sometimes that leads people to just not want to talk about it at all. For some people it was a difficult thing. Well, for most people it's a difficult thing to go through, obviously. But it's not necessary to share every little detail. It's possible to just share the fact that this is what's happened, and here are other people I know in the family that have had this, and that's really all you need to discuss. That's the key. And we also recognize it's hard sometimes to ask others about their history. I think sometimes what prevents some from discussing genetics or this whole field of the possibility of hereditary cancer risk with their family is it's daunting. I mean, let's face it, it's daunting. The field of genetics can be difficult to understand. We've all, gone through some of the information this morning and learned that, yeah, it can get really complicated. But it's not necessary to know all the details and ins and outs of genes and genetics and genetic risk to still be very helpful to your family in sharing information. Just like everyone's car needs maintenance, you take it to the garage where they're experts in how to maintain an engine. You don't need to be an expert in how everything works from the interior on outward to derive value from going somewhere where they know about this. You don't need to know and understand the ins and outs of genetics to the nth degree if you don't want to. Some people like all the details, and that's terrific. And other people are more focused on, I just need to know what I need to do and how to best advise my relatives. Don't let the fact that genetics can be complicated get in the way of sharing. So when you're talking to family members about family history, what are the important points to discuss? What are some of the main overarching things that we think can be helpful to share? One of the things that we always suggest is that people recognize that knowledge about the presence of genetic risk can help make things better. That's the bottom line. And that can sometimes move people past their fear of even delving into the topic. It's scary to think about the chance that your relatives might have cancer. It's scary to think about the chance that you might be at risk for other cancers. The whole field can be a little bit overwhelming, and we understand that. But if it comes with an understanding that there are things to do about it, there is special screening available. We know that it does change the way family members may be managed. For example, some relatives may benefit from starting screening at a much earlier age. One of the common things we hear is, well, why does this information need to be identified about genetic risk? I mean, you can't change your genes, so why go there? Why worry about it? And again, the message is there really are things to do. So, for example, we start screening our ladies who have genetic risk due to BRCA1 and 2 at age 25. And 25-year-olds in general are not screening. They're not getting mammograms. They're not doing a lot of the things that may be beneficial to them. And if we can help identify those young people, we may be able to help them tremendously. When you go into a genetic evaluation, it's also possible that some relatives will learn that they are not at any higher risk than the average person. And what a wonderful thing to be able to learn when you're from a family that has lots and lots of cancer history, that yes, there is cancer risk in this family, but actually you didn't inherit it. That's a wonderful thing to learn. And we believe that if there is a suspicious family pattern there, that not knowing about why it's there or not dealing with it, it doesn't mean it's not there. It just means that you're not dealing with it, and maybe you're depriving yourself or family members of things that might truly benefit them. So yes, it can be scary, but it's important when discussing these issues with your family members that there are experts out there at Penn and at other places who can help. We can help not just with making sure that people get the right care, but also we can help with informing your relatives about things that they need to know about. As a genetic counselor, one of my primary roles is to help families not just understand the information for themselves, but also how to get that information to others. And what some people do is they will explain to a relative that this is what's going on, and there's a person at Penn named Jill Stauffer. Here's her email, here's her phone number, call her. And if that's all you do, that's terrific. So I want to talk about 3 different scenarios and how it may be important to share certain pieces of information with your family. Scenario 1, when there is a gene mutation that's been identified in BRCA1 or 2. Scenario 2, there's maybe suspected genetic risk. There is a family pattern, but there is no detected mutation on any test that we have. And scenario 3, where, and some of you might have experienced this, where genetic testing has been done, but we find that variant of uncertain significance, or we find an unclear genetic testing result. How do you talk to the family about these different issues? So in the case where there is a known BRCA1 or 2 mutation in the family, who is it important to tell? Well, it's important to tell all your close relatives. So that includes your children who are adults. We'll talk in a little bit about the issues in children who are minors. It's important to tell your siblings, both brothers and sisters. It's important to tell people like parents, aunts, uncles. And it's especially important when you think about your own family history to think about those who've had a related form of cancer, so a breast cancer or an ovarian cancer. If there are descendants of those individuals, those are people who may be particularly at risk of also having a gene mutation. Sometimes the parent who's had a related form of cancer, who may be an aunt or a cousin, if they're deceased, there may not be someone who is immediately related to that person who can inform that relative of the presence of genetic risk. And so it can be especially helpful for the family to reach out to those people. So here's a family tree where the source of genetic risk became known. The first person in the family who was identified with genetic risk is on the right side of the family tree. She's the circle on the bottom row. She was diagnosed with breast cancer at 35. You can see, interestingly, her mother had breast cancer at age 58, but her mother is not the source of genetic risk in the family. It actually comes through her dad's side. And that was made clear to us when we looked at the family tree and saw up through dad's side there were a couple of women with ovarian cancer, and on dad's side there was also a young woman who developed breast cancer at age 29. This family did a really good job of informing others about the presence of genetic risk. And I want to point out, if you look all the way on the left side of the family tree, on the bottom row, there's a young lady who has tested positive for BRCA1 mutation, and she was tested as a young woman in her late 20s, and she's been having special screening, and she's been doing really well. She has a relative with breast cancer who is a grandmother diagnosed at 51. And for most people who went in and talked to their doctor about, well, tell me about your family history, having a grandmother diagnosed with breast cancer at 51 doesn't really inflate your risk all that much. And it's very likely that this young woman wouldn't be doing anything like what she's been doing because of her awareness that she carries a BRCA1 mutation. And it's only because of the fact that the testing kind of continued. You can see she inherited it through her father, and then there's another man in that generation who also tested positive. It's very possible that this young lady may never develop a cancer, or she will again benefit from all the things that she's been doing, and it's only because her family took the approach that they made sure everybody knew about it, not just their close relatives, not just sisters, not just parents, but they reached out and testing continued all the way through the family, and people who could benefit did. So when there is a genetic risk due to BRCA1 or 2, this is how it works. It is a dominantly inherited condition, the condition being increased cancer risk, not cancer. So you can see someone who has a BRCA1 or 2 mutation that has the trait being increased risk, but perhaps never developing cancer. So in this case, the father is the one who carries the genetic risk, and because all our genes come in a pair, one or the other gene in that gene pair gets passed along to the next generation. In this family, the mother does not carry genetic risk, so the only type of gene in her gene pair she can contribute is one that works or one that works. She's only got functional copies of her BRCA gene, whereas the father has 2 different versions, one that works, one that doesn't. So there's a 50-50 chance based on the fact that one gene or the other gene in that gene pair from dad is going to go to the next generation. And then you can see if you don't inherit this type of genetic risk, like the 2 individuals on the left there is not a faulty gene there to pass to the next generation. If you don't have it, you cannot pass it. And that can be a very empowering thing to know also. So if you've been through the genetic testing process and you learn that you have a BRCA mutation, we all understand this is a big deal. and it's an adjustment, and it's something that happens over time. But when is a good time to start sharing this information with your relatives? We would argue as soon as you feel that you're able, and hopefully, provided that's not years from now, that the fact that there are things to do about cancer risk, and there are other people in your family who may be at risk right now, we feel there's some sort of a moral duty to try, recognizing that it's hard. There's some type of a moral duty to try to inform your relatives, and again, not just your close relatives, but to get it out in the family that there is detected genetic risk so that people have the option of taking advantage of this information also. And how to tell? It's hard, and every family is different. Some family members tend to be on the same page about this, and there's a lot of interest, and everyone is receiving the information with interest and wanting to be proactive. And then there are plenty of us who have families where that's not necessarily the case. There are people who are resistant, they don't want to know. So sometimes a good place to start when you're having the conversation with your relatives is, what do you know about this? What have you heard about genetic testing, or have you talked to anyone about the possibility of hereditary risk in our family? And it'll give you some information about where you're starting with the topic. With some of your relatives, you know them so well, you don't need to do this. You sort of already know where that person stands. But perhaps with aunts or uncles or cousins or people who are not necessarily as close to you, you kind of may not know what their underlying understanding or interest is. And that's always a good place to start, because then you kind of know what to expect comes next. So you can start by asking that question, and then just simply share the fact that you've had this testing, that you've been found to carry genetic risk, and that there are things to do that can improve your situation, and that's why you did this testing, and you're hoping to make this information available to them so they can do the same. Not everyone in the family is going to be interested or wanting to know all the nuts and bolts and all the details, and other family members are going to be hungry for information. And you kind of know your relatives. Maybe the way you share the information with someone who's in their 80s is going to be different from the way you share the information with a younger person who is a molecular biology major, right? So you don't have to have a prepared message that's the same for every person. Know your audience. And again, you don't need to share all the ins and outs about how this went for you. Some people are comfortable doing that, and they find that's the way it works best in their family. But there are many of us who come from families where perhaps your family lives all over the place. Perhaps there are some conflicted relationships. Maybe you're not that fond of all these people. Again, don't feel like you need to go into all the details about how this experience was for you if you're not comfortable. You can share the information that there's genetic risk. You might benefit from this too, and that is the key. You don't need to go into more than that. You can let your relatives know about next steps. If they're local, you can say, this is where I've been seen, or that there are people who are experts in cancer genetics, and why don't you talk to your doctor or your nurse about where you can go, because it's important to follow up. Another detail is, if you've had genetic testing and you've been found to have a detectable gene mutation, your relatives will need a copy of your laboratory report in order to have the appropriate test ordered. When there is a known mutation in the family, it's like knowing exactly what page of a book a spelling error is on. And you don't need to examine every page of the book at this point. You know how to focus in exactly on the right place. It's a different laboratory test. And so it's helpful to maintain a copy of that somewhere in a safe place where you keep important documents. When there is a gene mutation in the family in BRCA1 and 2, a very common question that we get is, what's a good age for my children to consider testing? Is it a good idea to test children? What about teenagers, young women? When do we start with this? And we recognize everyone wants to protect their children. And some people, I think, feel like, oh, we have to test the kids right away because we need to protect them. But we take a step back and think about it. We know that this can be scary information to receive about having a much higher chance to develop cancer at some point. What good is it going to do to know this information about a 7-year-old? Is there anything different that we would do to that 7-year-old to protect her, to reduce her chances, to screen her? The answer is no. There's really nothing to do for a child other than honestly worry about that particular child. If there were anything to do that would help that child, if there was an intervention that would make their situation better, we would test children. It's not that we have a fundamental aversion to testing children for genetic conditions. There are other conditions where there are things to do for children where we are very encouraging of it. In the case of BRCA1 or 2, there is nothing to do any differently other than worry, so we do not test children. At age 18, still a child, I would argue, it is possible to do testing. They are of legal age to make this decision for themselves. But again, what value might it be to that young woman? And I would say that the answer has to be based on that young woman. In general, again, there's nothing we're going to do for a young woman slash teenager slash child at age 18. There is no screening that starts. The magic age for us becomes about 25, because that's when we start doing mammograms. If she had it also, that's when we start doing MRIs. That's when things really change. And prior to the age of 25, again, it can be very frightening information for someone in that age to receive the information when there's nothing to do about it. And in our personal experience in working with some families where testing has been done all with the best intention of helping these young people, the outcomes have in some cases been rather terrible on a psychological basis. It's been very hard for some of these young people to deal with the information, and sometimes they start getting screened inappropriately, and it leads them down a road that's just really difficult. So the overarching thing that we think about is that at the age at which medical decisions need to be made is the good age to start testing. What about the situation where someone's had genetic testing, but there's no mutation that's been identified? And here's a family with lots of breast cancer and ovarian cancer, and the person with the arrow who had genetic testing did not have a mutation identified. A common response that we'll hear from people in our clinic is, oh, good, the testing was negative. And then I feel like my middle name is Wet Blanket. It's Jill Wet Blanket Stoffer, because unfortunately, this family has something, but we just don't know what it is. We don't know if we're missing a mutation due to lab technology limitations, it's some other gene, it's some other set of genes. So when the family has gone through genetic testing, the meaning of a negative result really differs depending on the situation. And the only time that someone really has what we call a true negative, when there is a suspicious pattern in the family, is when someone else in the family has had detectable genetic risk. If there's a positive result in someone else, we can say to ourselves, we know why the cancer is present in the family. We have sorted it out. We can peg it to this gene, and you don't have it. That's a real negative result. Unless that is the scenario, though, we call them sometimes uninformative negatives, that maybe the pattern in the family still looks suspicious. We just don't know what it is. Sometimes we've tested an affected person, like in that prior family tree I showed you, and we have a negative result and we are saying it's something else. Sometimes a person who's gone for genetic testing has never had a cancer diagnosis, but we don't know, is your test negative because you didn't inherit whatever's going on in your family? Or is there some sort of undetectable risk, and we can't tell which category you're in? So interpreting a negative result really depends on the context of what's going on. So in talking to your family, if you've had negative genetic testing, unless the situation is that you've been a true negative, you need to say to your relatives, continue to talk to the family about our history, because despite my negative genetic testing, there still may be something going on, and your doctor, your nurse needs to consider that in making recommendations to you. The last category of genetic testing result that sometimes people will try to talk to their relatives about is this variant of uncertain significance. This is a very frustrating outcome of testing where the testing's been run, but we don't understand what the results mean. Genetic testing relies on the laboratory looking at the spelling of your genes and asking the question, based on the sequence of letters in your genetic code, do we think this gene works or not? And usually the answer is clear-cut. We can say, yes, this spelling is fine, or no, this spelling is not fine. But occasionally we get an indeterminate result. This is an example that theaters can be spelled two ways, T-E-R, T-R-E, depending on which side of the Atlantic you live on or how pretentious you are. And we know that there's variability in the way you can spell words. There's also normal variability in the genetic code. When there is a variant of uncertain significance, we cannot track cancer risk yet in the family. And we don't advise that anyone else in the family get tested for it outside of studies that are designed to try to figure out what it means. So it's important to be tested in a center where they can explain these results appropriately, because then we can figure out what the next steps should be. But in general, you cannot use a variant of uncertain significance to tell people what their risk is. So common reservations about sharing information in the family. Often that come up, I don't want to upset my relatives. Totally understandable. Who likes to be the messenger of bad information? My relative is going through a lot now. Sometimes this happens when we're suggesting that the person with cancer be tested in the family, and the unaffected cancer-free person is the one who really wants the information. They say, oh, I can't bother my mom. She's going through so much right now. Sometimes that person who is going through a lot actually relishes the opportunity to provide information that may be of benefit to their family for generations to come. So despite the fact that your relative may be ill, they still may really want to participate. And so all of these are things that I think many of us will deal with and can recognize. So pointers for communicating the information in the family is that, yes, the information may be hard to understand. Some of you who've been in the world of are very medically sophisticated. You know the lingo. But when you're talking with family members, try to avoid some of that so that it is more understandable. Only give your personal opinion about what to do if asked. How many people like being told what to do by their relatives? In general, it's even if you feel like you know this is what should be done, unless you're asked, you don't need to outline a plan of action for themselves. You can share printed information. We have booklets that go through all the details of what it means to have genetic testing that we're happy to share, and other centers do as well. It's most helpful to communicate with your relatives directly, if it's at all possible, as opposed to delegating that responsibility to someone else, because this way you can be sure it gets done. That doesn't mean you shouldn't enlist the help of your relatives, but that can be best. When you're sharing this type of difficult information, it's important to listen also, to not just be spewing the information, but to listen to what your relative is saying and make it more of a conversation. People sometimes communicate through various modes. In person is always best if it's possible, but the telephone works. Some people have used emails. Some people have actually set up websites. I know that there are a number of families we work with where I'm on a website and I'm the contact information, and that's great. And people direct their relatives to go to this place and get the information. Honestly, whatever works for your family is the best. Even writing an old-fashioned letter to your relatives can be a nice way to do this. So in summary, when we talk to relatives about something that is difficult, like there may be hereditary risk in the family, it's important to say, well, no, we don't have all the answers, and this is not a crystal ball that's going to tell everyone what's going to happen, but there are some things you can plan for and some things you can't. In the case of detected genetic risk in the family, or in the case of we know that there's family history of this, that, and the other, it does move you into the category, well, at least we're doing what we can about it, even if we don't know everything. Knowing about family history helps. We're all unique, and we all need to do this in our own way. There's help. There's professional help. There's supportive help like Force, and you're not alone. So, thank you.
Great. Thank you so much, Jill. So, is this on now? Do you guys know? Can you guys hear me through here? Yeah, okay. So, recognizing that usually what people like best about these kind of conferences is the question and answer session. We're going to get started. So anyone want to start? Yes, in the back. Yeah, it's a great question. So the question, just to repeat it so everyone can hear it, is how about telling your sons about a BRCA1 or 2 mutation? And so one of the other reasons that sometimes people get genetic testing is something called Preimplantation genetic diagnostics. And some of you may have heard this term, PGD, and others may be looking at me funny, but basically the technology is now available that individuals can go through in vitro fertilization and actually have the embryos that are created assessed for BRCA1 or 2 mutation, and then only those embryos that do not have the a mutation are reimplanted. So people tend to have pretty strong feelings about this. Some people think that, like, what are you guys, wacky? And others people are really into it. And we are the messengers of this information. But that technology is available. So sometimes men get tested, and even women get tested earlier than 25 for family planning purposes. And again, that's not for everybody. It's not covered by insurance.
That's actually not.
Well, for BRCA1 or 2, we've never had anyone covered.
So
by
it's actually
insurance.
really changing. So I do this a lot more in my clinic.
Yeah, but I think it may be more relevant. It may be true of the other genes. It is changing though. So
yeah, it's getting more covered.
Kate, because of some of the genetic susceptibility that Kate does, a lot of those genetic syndromes, the PGD's been around a lot longer for, and so it sounds like there's coverage there.
Yeah, so
right?
that coverage is actually the insurance companies, and I assume it's actually also true for BRCA1 too, are really sort of starting to change how they deal with PGD. And so it used to be it was almost never covered, and now it's actually changing. And so it's really insurance company dependent, and there are certainly insurance companies now that do cover PGD.
Yeah. So that's great to hear. And what we usually do is, if people are interested, we send them specifically to the folks that know about this and can assess the insurance cover. So that's the one issue. Again, not a reason for everybody, but that's out there. And then for men in general, our recommendations are based on like no evidence whatsoever, which is disappointing. So we talk about things like making sure that men know that they can get breast cancer, because as you can imagine, men don't think they can, and most men with breast cancer present later than women because they don't think that a breast lump could possibly be cancer. So a lot of it is about awareness. There's melanoma risk. For prostate cancer, we really don't start PSA screening anyway till 40. So oftentimes we talk about for men, 40 seems reasonable as long as they know that they can get breast cancer. We really don't have any good data on mammograms in men, for instance. And so we have an ongoing study, this something called an impact study, which actually will test men starting at, I think, age 40. Jill, do you remember? Men at age 40 with a known mutation in the family will do their genetic testing for free, which is also a problem because for a lot of insurance companies don't cover genetic testing in men. That it's also to specifically look at prostate cancer screening to see whether it can be helpful. So, Jill, did you have another comment?
Yeah, and then the other thing that I would add to that helpful information is there's two issues too. There's the issue of sharing the fact that there's been genetic testing, there is genetic risk in our family, versus making the decision to be tested yourself. And the way information gets shared that there is genetic risk in the family is so personal and family specific. You'll find that some people and some families are very comfortable sharing the fact that, as you know, mom's had this diagnosis, and I just want you to know we have this going on in terms of genetic risk, and one day this will be relevant to you. A lot of times you can be guided by your kids' questions, what they want to know. Again, you don't need to share every last detail of what's going on, especially with a younger person, but it may be fine and helpful to share the information that there has been genetic risk identified in the family and kind of leave it, and that's an issue for a later day. Or you as a parent may say to yourself, I know my kid, and right now my kid is going to be reacting very poorly if there's this additional stressor piece of information shared. And then as the parent, you make those judgment calls about when is a good time to share. But just, again, the two are not synonymous. Knowing about genetic risk doesn't mean that that person is going ahead with genetic testing at the same time.
Right, great. Other questions? Great, sure.
Hi. I've been on tamoxifen for 5 years, and you said there's an increase of uterine cancer.
Yes.
Is there anything I need to do to be tested or monitor?
Yeah. So, and just as an aside, I'm going to answer these questions generally, as you might imagine. But So actually, so in women who are postmenopausal, particularly, the uterus is actually kind of a nice bellwether. It tells you when there's a problem by bleeding. So in women who are on tamoxifen and postmenopausal, any bleeding is abnormal bleeding and needs to be evaluated by an endometrial biopsy. Absent that, we don't actually recommend routine uterine cancer screening because tamoxifen always thickens the uterine lining. So if you get an ultrasound while you're on tamoxifen, you will end up with a biopsy, which is really, frankly, not necessary unless you're having abnormal bleeding. For premenopausal women on tamoxifen, it can really mess with their cycle. So there's no sort of standard. It kind of depends on what changes sort of are occurring. But in general, premenopausal women, the thing that we don't like is when people have bleeding in between periods. So, you know, if in between a period they have a weird episode of spotting, that kind of gets our attention. But yeah, no routine screening on tamoxifen. Yes, over here.
I have BRCA1. I'm an 8-year breast cancer survivor. I also have a 13-year-old daughter, and I know you guys said that there's nothing that you do at that age, but I also heard that you certainly look very carefully at how long a person menstruates. And now there are birth control pills out there that can control how many times a year you menstruate, and is that something you might recommend?
Yeah, wow, good question, great question. Okay, so the short answer is that we don't know. But however, there are some data that actually the devil's in the details about birth control pills, and the pills where you only have periods a few times a year keeps you prolonged in what we call the luteal phase, which may be bad for breast cancer. Okay, so it's not so simple as actually how many times you have a period, and really having a period on birth control pills. What we're really talking about having periods is actually ovulating, which is a different situation. And so when you're on birth control pills, you're not ovulating. So that's why, in part, ovarian cancer decreases your risk. Birth control pills decrease your risk of ovarian cancer. But the birth control pill breast cancer stuff is much more complicated. I kind of glossed over it in my talk, but some initial studies suggested that there potentially was a slight increased risk of breast cancer in carriers on birth control pills, but they included women who had taken birth control pills like in the 70s when they used very high-dose estrogenic pills. And the more recent data suggests that there really isn't an increased risk. And this is like a complicated subject. We don't understand all of the interactions, but I think that this question of testing kids is complicated. And we actually have a colleague, Angela Bradbury, who's at Fox Chase, who's very interested in this question about communication and testing. And I think that we always have to be we have to be careful because maybe many of you in this room considered whether they were going to get testing and went through those pros and cons in their mind about that. And then imagine, you know what I mean? Imagine, like, if you will, if you're testing a child, you're kind of making that decision for them and taking away that empowerment, which is what a lot of this is about. So, I mean, it may be that in 10 years we have specific recommendations for 13-year-old girls with mutations. And when we have that, we will find a way to communicate with those young girls and test them. But right now we don't, and that's why the recommendation. Now, having said that, there's some things that all kids should do, which is, number one, this is one of my personal pet peeves, but like 85% of all sun exposure happens before age 18, and melanoma rates are rising in the U.S. This is not related to BRCA1 and 2, but that's one thing we can really do. And regular exercise and maintaining a healthy weight are really important things for everybody. And honestly, like, the one bad thing about girl empowerment over the last 30 years is that we smoke and drink, more than we did. And that's actually, not good for us either. So those are all things that, are things that we can do, and those are the things that everybody should do. So I know I didn't directly answer your question because there's no direct answer. So, and peach. Yep, in peach. I think that's peach. Would that be considered peach? Peach.
Yeah, peach. Notice that we're all women here, so we know those things.
The color, yes. Yeah. We decided it was your peach.
What other cancers tend to track with BRCA1 and BRCA2 besides breast cancer and
do you want me to?
gynecologic?
Right. So this is actually a really interesting issue for us. And so this is So male breast cancer is something that you can see in both families with BRCA1 and 2 mutations, particularly in families with BRCA2 mutations, but not exclusively so. And I think that's used to be somewhat of a misapprehension. Pancreatic cancer has certainly seen, particularly again associated with BRCA2 mutations. We talked about prostate cancer as well being associated with BRCA1 and 2 mutations, particularly again with BRCA2 mutations. I think there's several things that are interesting. We've actually done a study which Susan led looking at childhood cancers and did not see an increased risk of childhood cancers, which is obviously important when we're talking about testing children. So that's an important issue. One of the things that you can certainly wonder about what's going to happen is that while we think of this as predominantly breast and ovarian cancer susceptibility, and that's what people think of, these are really, particularly with BRCA2, general cancer susceptibility syndromes. They still increase the risk of lots of other cancers, just not as much as BRCA1 and 2. And as people get to be treated, particularly with prophylactic oophorectomy, and really decrease their risk of breast and ovarian cancer, some of these other cancers may actually become more noticeable / predominant, and where you're going to see women, unfortunately, develop relatively unusual cancers because we've taken care of the risk for the main cancers, and now we're sort of, unfortunately, occasionally seeing some more unusual cancers.
Right, but we don't know that yet, so don't get scared. Don't get scared. No, I mean, I think that it's a really important question, though, because as we prevent breast and ovarian cancer, we want to make sure that nothing else is popping up. And there are some ongoing studies also about pancreatic cancer screening, particularly in BRCA2 mutation carrier families with pancreatic cancer. And there's a physician at Penn named Mike Coachman who does pancreatic cancer screening. We really don't know how effective it is, but these are, again, all very crucial and important questions. Melanoma is easy, a skin check. Prostate cancer, for what it's worth, is easy with a PSA. We're going to ignore the Preventive Task Force guidelines for a moment. Breast and ovarian, we're all over. Male breast cancer is hard because even in the BRCA2 carriers, the lifetime risk is 5 to 10%. So what, you're going to commit a man to a yearly mammogram, for that level of risk? They're not exactly enthusiastic, by the way. Every man I've had who's gotten one, that was the last one they got. So we'll see how that evolves. But again, we hope for better guidelines and better recommendations. I think there's a question by the door. Go ahead. Whoops. Oh, no, that's not a question. Okay. Someone had a microphone. I was thinking it was a question. Go ahead.
My father had pancreatic cancer, and his sister had breast cancer at age 70. So should I be tested for pancreatic cancer?
Well, yes, great. It's a great question. The lifetime risk of pancreatic cancer associated with a BRCA2 mutation, just taking everything aside, is about 3 to 5%, which is not terribly high compared to 1 to 2% in the general population. But we do know that certain families with BRCA2 mutation pancreatic cancer can run in those families. So your risk may be higher than that. The question about pancreatic cancer screening, though, is that I can't tell you for sure that it does any good. And that, it's one thing if you have a false positive, if you will, MRI or mammogram where someone's going to do a breast biopsy. It's another thing to have a false positive screening for pancreatic cancer because, the pancreas is kind of in the middle of you and not exactly easy to get at. So, the short answer is that we hope to have more detailed information about the risks and benefits of pancreatic cancer screening. Right now, the really standard recommendations are when there's familial pancreatic cancer, kind of defined as 3 or more cases of pancreatic cancer. Well, probably that's a good idea to look at that. But a real area of controversy is this area. So we do talk to people in your situation, BRCA2 mutation carrier with a family history of pancreatic cancer. We do talk about it. Right. Well, the breast cancer would be kind of anticipated due to the BRCA2 mutation. So it's really that pancreatic cancer that raises the question.
So everybody gets screened, obviously, for breast cancer. So the issue is when should people be screened for pancreatic cancer? And it's just not. There's no good answer, and it's also not clear. I mean, obviously we know that screening for breast cancer is very effective and really helps improve outcomes. The question for pancreatic cancer is the screening going to improve long-term outcomes? And that's still not entirely clear.
Yes, up front.
with a history of breast or pancreatic cancer within the family.
Right. So the question is, are there pancreatic cancer screening trials? Yes. So at Penn, again, this Dr. Michael Coachman does endoscopic ultrasound for this, and that actually has been billed to insurance, but we've been trying to follow the cohort along to actually try to get that answer. In terms of larger studies, Johns Hopkins has always had a very active pancreatic cancer screening study cohort. When I last checked, and I admit I haven't done it like in maybe the last 6 months, the study part was again following you, but they also at that time, but again I can't guarantee about it right now, we're billing the actual screening to your insurance company. It's because the screening is expensive. Now, having said that, because now what we're doing is an endoscopic ultrasound, and there's a lot of indications for endoscopy, including like having heartburn and stuff. You know, we're getting not all, but a reasonable amount of them, are covered by insurance. So that's the short answer is we don't have an open trial at Penn apart from this sort of prospective cohort that we're following, but there are studies at Johns Hopkins and a couple of other places that are trying to answer this question. So we hope to have more definitive information within the next few years.
But I think I would clarify, but that doesn't mean we don't offer pancreatic cancer screening.
Yeah.
We just don't have a specific trial to do it.
Yeah.
But that doesn't mean we don't have patients who do have pancreatic cancer screening.
Thank you.
Yes.
I think that she's really asking too, and I was asking because right now my insurance stinks. Well, if you're not, what you're saying is if there's a deductible or something that we have to pay, then you're not covering it, right?
Well, right at Penn, and that's why I don't.
John Hopkins might.
I think again, I can't speak for their study as it current stands right now, but when I last looked into it, they were billing your insurance company too. So
okay, but there might be billing, but then.
No, they still won't cover the deductible.
You generally can't do that in a medical center. You can't pick. It's actually. Well, I don't want to get myself into trouble by saying it for sure, but you can't pick up just the copay because there's reasons that can't be done. Yes.
I want to get back to I have 2 girls. I'm a BRCA too. And I have not come out of the closet. And my 14-year-old is asking me, my dad died of pancreatic cancer 2 years ago, and she's asking if there's any genetics in the family. And once I come out, I come out. My mother-in-law just died of lung cancer. So they're aware of all these things. And I don't know if you wait till 18 or you wait till 25. I mean, then they're resentful that you didn't disclose the information. And I've seen a lot of people really screwed up at a young age.
Yeah. Well, this is where I would actually make a huge distinction between disclosure and discussion and testing. Okay, because those two are distinct. So actually, I think discussion and talking with your daughter is totally fine. Now, it's a little bit like I have an adopted kid. I don't know if anyone else does here, but they talk about like when you never lie, but you answer the questions that are asked. Like you don't have to get into every last little detail because it can be overwhelming. But lying, and I'm not saying you're lying, you're in the closet, which is totally different. But lying, they catch you out and they're mad at you, right? Because they don't want to find something out about themselves later that you knew all about all along. But I think there are ways, and again, we can help you with this, offline. And Force, I think, has a lot of experience with it too, of sort of, how to answer her questions without, frightening her, because that's really what you want to do. And if she's asking the questions, then she deserves an answer. But again, not necessarily every little detail.
That's right.
Mm-hmm. So
you don't
Jill,
need to get right. I mean, and there is some evidence too that young people sometimes handle things better than we think they're going to handle them. A lot of times, there is a remarkable amount of resilience, provided that the information is given in an appropriate manner. Appropriate to her and her questions and her level of understanding, that it's given along with a message of hope, that it's given along with a timeline that, honey, let's also talk about the fact that this is not something you need to worry about for a very long time, although it's good to know. And I think increasingly people are going to know more and more about their genetic risks for fill in the blank. Yeah, that's going to be a more typical experience from more families as time goes on. And so it may be that even though it's so scary to share this with your daughter, if you can think about it in an empowering sense, giving the information that she's asking for without feeling like you need to get into every nut and bolt, but just answering her question now, if she's asking me, avoid that resentment if it comes out later that, Mom, I asked you that 3 years ago, and how come?
Right. And that's what I'm dealing with. But it's like, it's not just like once I open, I mean, my aunt has it, my brother has, like, it's not just once I tell my 14, there's other people involved, and she's going to ask other people whose mothers have had the genetic. I mean,
so you brought up two points that I wanted to emphasize. One is, and we always talk about this, is that when we're never testing an individual, we're testing a family. That's why we feel that pre-test counseling is so important for people to understand that, because we have had cake in common. There was a recent case, and not related to BRCA1 or 2, where someone was like, some testing was sent without any counseling, and then when it came back, that's when he figured out that it had all these significant implications for his kids, and freaked out, because you have to know that going in. So I think that that's a huge point. But also, this is why I like that force video so much. This knowledge is power, and we can change what happens to people because we know this information, and that has to be a real message for your daughters and for your kids, which is, because we know this information, we can change what happened in the family, that it doesn't have to happen to you. And I think that's a huge message. Kate,
yeah, so I actually didn't say the same thing, different words. So my sister-in-law is a lawyer, and she said to me, how do you give bad news to people? And I said to her, you never give bad news without a plan. So you have a way to deal with it. That's the crucial point, that you say, yes, there's this, but this is how it gets dealt with. So you always give, the way I think about it, I'm sure the way Susan thinks about it, you never give bad news without how you're going to deal with that bad news. And that's the way I would say to your daughter. I think that she's asking you those questions, and you're going to think about how to appropriately answer them, but you're also going to be reassuring that, yes, this isn't, great news, but we have a way to deal with it.
Well, and I would even consider reframing the news as bad news. The bad news is that the history is there, and she's aware of the fact that there's cancer in the family, right? So
the bad news
is that it's there, and we wish we could wipe that all away, of course. But the good news is that we understand why. So for a lot of individuals, learning that there is detectable genetic risk is actually not bad news. The bad news is that there's cancer in the family, but the good news is that we know why. Our family is going to be the type of family to benefit first from understanding and getting these options to deal with our cancer risk, doing things that will lower our cancer risks, potentially benefiting from specialized therapies and so on. So the fact that there is detected genetic risk sometimes is actually viewed as good news.
So we're happy to talk to anybody about these issues. And again, Force has a lot of knowledge about this too, but your providers, whoever did your genetic testing, these are issues that we expect to be asked, and we can help you, and each situation is different. So we're happy to help you get a plan for that. Yeah, another.
Yeah, I have 3 sons, and especially my 2 older ones, because one's 40, one's 43. I, would like them just go for the testing, but they keep saying they're not doing it.
Right.
There's no reason, and yet their cousin has it, and not Lisa, but her brother. So I think it's and they say, why? And I say, well, because you can get additional screening, whatever is entailed for, it's covered.
Right. I think our argument will be made much stronger. I think we'll be able to convince a lot more men when we have a lot more data about how we're helping them. I think right now we have a lot of data on how we can impact what happens to women, and we have less data on how we impact men, and men are just reluctant to go to the doctor anyway. So they're already harder to, I'm just speaking generally, everyone knows that. Don't hold it against me. But, men are just sort of.
They also don't know their family history.
Yeah, they don't usually know their family history too. But it's just harder up front, from the get-go. And so I think that it's our job up here to come up with the reasons why men should get tested. And I think that one thing that usually works is once they have daughters, then they all come scurrying right on in, because all of a sudden it has a more immediate and direct impact. When we're talking about impact on their health, they do tend to be, and honestly, we don't have as great data, so it's a little harder to convince them. So as long as they're doing things like recognizing that they could get breast cancer and talking to their doctors about PSA screening because, again, the prostate cancer issue is different and they should be talking about their family history anyway of pancreatic cancer. So, these are the things that if men aren't going to get tested, and we always say this to people, if you have a daughter who doesn't want to get tested, and remember, you give them the information, it's theirs to do with what they want. But if you have like a daughter who's in her 30s and there's a known gene mutation, they won't get tested for it, fine, we'll screen them anyway. We treat them as if they're high risk, even if they won't get testing. So that's really an important thing is that, okay, you won't get tested, we're going to screen you anyway.
Yeah, the other thing, I'm sure this is true, the wives bring them in.
Yeah. We get a lot of
the wives are like
handcuffs. Yeah.
And I think you'll find that people evolve into their testing decisions. Right. There's the issue of should I be tested, but the issue of when to test is also very variable. And in some cases, people are just reluctant. They're reluctant, and then at some point they reach that change where now they're ready. And so that's just the way it goes. Yeah. Everyone has to make their own choice in their own time frame.
But it drives us nuts too, for what it's worth. Yes, right there.
I have a question about hormone replacement therapy. And I've talked to you about this, and I have scripts in my bag, and I don't know why I go back and forth with this. But my question is, so I met with another the gynecological oncologist who did my oophorectomy, who said to me, you're not symptomatic now, your life is good, you're not teary. Why don't we get baseline bone scan and baseline cardiology reports, and we're going to track you starting at 6 months and then every year? Is that an option? Is there a point where it's too late? And
no. It's a great question, and we don't. It's easiest for us. The question of hormone replacement therapy. And if we were able to do a randomized control trial, and again, half the women get hormone replacement therapy and half don't, and we get to look at everything from symptoms to bone health to cardiovascular health, and then be able to sort of give people very specific data about that. That would be awesome. But we don't have that. So we're more pragmatic about it. So if someone does have a lot of hormonal menopausal symptoms, then it kind of becomes easier because there are non-hormonal mechanisms, by the way, to help with menopausal symptoms. There are other medications, but that is one component. And we know that HRT helps those symptoms. Exactly what the effect is on bone health and cardiovascular stuff is just harder to know. I personally think there's pretty good data that hormone replacement therapy helps bones, but I can't tell you so much exactly what it does to the heart because that's been complicated. So yeah, I think there's there are definitely lots of reasonable approaches. It is reasonable to, and that's why I don't want anyone to think, it's come away from today thinking that I'm like, oh, if you don't take HRT, that's stupid. Not at all. It's nice to know it's an option. But absolutely, doing that kind of follow-up is realistic. The problem with some of this stuff is that we don't know that there are some other data from sort of the general population, and it may be that you can't detect now what's going to happen in 10 years, and we just can't know that right now. So that's why we are actively trying to figure this out. We actually are doing, we're trying to look more at these bone health issues and cardiovascular endpoints. We've started very generally now, but we're actually really committed to looking at more specific markers of cardiovascular and bone health risks that we can give you the answers that you need to make the decision, which you don't have right now.
Okay, thank you.
What's that? Oh, cognition. That's another thing. We do hear a lot. The other two kind of issues, which kind of go along with the menopausal issues, but we do have people who complain of cognitive impacts of menopause. And again, exactly what HRT does there, it's hard to know. In non-randomized studies, in studies like the Nurses' Health Study or something called the Mayo Clinic, when they looked at women who had their ovaries out and didn't before 45 and didn't take HRT versus had their ovaries out before 45 and did take HRT, things like bone problems, cardiovascular problems, and cognitive problems were somewhat less in the group that did take it. But again, not a randomized trial, lots of biases, and so it's the imperfect data that we're dealing with over there.
Hi, I'm not sure.
That's not working. Sorry. Yep. Yes, absolutely. So the question is about work being done on other genes. So Kate, you take that one.
So I think there are sort of two levels of other genes. So as I talked about, there's sort of these moderate risk penetrance genes, which increase the risk, but not nearly as much as BRCA1 and 2. And certainly there's a lot of interest in trying to figure out how to communicate that information, how that's going to guide medical management, which we really don't understand. And this is something that we're particularly interested in trying to figure out. We're also developing really high throughput screening strategies, because one of the issues is that rather than sort of BRCA2, that's 1 and 2, that's 2 genes, but there's about 7 or 8 of these genes. And actually we have a 30 gene panel that we do. And so how do you screen? I mean, there's the issue of testing fatigue. You're not going to do one gene after another after another. It just, who wants to do that personally? And so we're trying to develop really high throughput techniques so we can do multiple things simultaneously and then move them into the CLIA approved lab, that's the clinical testing lab, so that we can offer it on a clinical basis. So not only are we trying to figure out how we can do it quickly and efficiently for the patient, but we also are trying to figure out how we're going to translate that information and how it's going to affect medical management.
And just to emphasize this, when we have a family that has tons and tons of breast cancer and we have negative testing for BRCA1 and 2, the one good thing is that there have been several studies that have shown that family probably doesn't have an increased risk for ovarian cancer. And again, 3 separate studies done. But they do have an increased risk for breast cancer, and they have that increased risk based on the family history that they have. So everyone in that family needs to know that and be managed as if they're at elevated risk. So some of these genes, like some, CHEK2 or PALB2, if you find a mutation in that gene, it demonstrates that you have about a double risk of breast cancer, which, by the way, doesn't mean double the way we think it does, like multiplying by 2. It's not quite like that. And so, but that is no different than looking at the family history on a whole. And so it's the same recommendations. So the other problem is when you start to test 30 genes, and again, we're doing this in a research capacity so we can figure this stuff out. But when you test 30 genes, guess what you find? You find lots of those variants of unknown significance that Jill mentioned, because now you're not just testing 2 genes, you're testing 30. So now you have, 15 times, the amount of junk mail, basically, that you've got. And so when you start to do that, you end up, you have to be careful. So this revolution in genetics and this next generation sequencing in whole exome is incredibly powerful. And we actually do know a lot more about genetics than BRCA1 and 2. It's all about how to use it, and that is what we're working on. Because and also what are the other associated risks? For instance, a gene called PALB2, there's some association with pancreatic cancer, but really how strong is that risk? And by the way, as we talked about before, what can we do about that anyway? So these are all the questions that are all tied together before we counsel. So we are actively working on it. Again, we've got a very large collection of samples contributed by many women over the years who have had early onset cancer, and we're going to do these screens so that we can even start to get a sense of what the landscape looks like.
Yeah, we don't have really been a great sense of what the frequency of these variants are, and certainly depending on your age of onset. And I think it's really important to really try to sort this out in an efficient manner.
All right. Other questions? Let's see what. Yep. Oh, you're loud enough. No, just kidding.
This is a little bit of a numbers question, but for unaffected carriers of BRCA1 and 2, have we pinpointed an age after which your hereditary risk is confounded by your, the general population's risk?
What a great question.
Clinical issues.
So the age, the question just to summarize is, we all know that breast cancer risk goes up with age. It's actually apart from being a woman, the number one risk factor for breast cancer is your age. So you're absolutely right that if you're now like a 65-year-old BRCA1 carrier, there's some element of getting breast cancer, not necessarily because of your BRCA1 gene, just because you're a 65-year-old woman living in the United States. And one of the ways that can sort of manifest itself is that many of you in this room may know that BRCA1 mutation carriers tend to get breast cancers that are triple negative, so estrogen receptor negative, progesterone receptor negative, and HER2/neu negative. But if you look at older BRCA1 carriers, actually suddenly more and more estrogen receptor positive cancers are sneaking in. So, why was that? Why did that cancer occur? from a management standpoint, it doesn't necessarily matter. But as we move into these more targeted therapies, like you'll hear more about later with these PARP inhibitors, maybe it does. So that's going to be a question in evolution. I don't, Kate, if you have any other comment about it, but it's an interesting question.
It's a really interesting question. So I know, it's hard because the population risk is so high, is relatively high. But we certainly have other cancer susceptibility syndromes in which they actually burn out after a certain age. So that if you hit a certain age, your risk really is you just don't get additional disease. And so I see patients who I'm actually able to counsel that once they hit that age, their risk is really decreasing.
You're too old to worry about it anymore. Yeah,
right, you're too old. No, I'm serious. But I think it's for this, and you're right, because of the population, we don't know where that interaction is starting to play a role.
Right. The other important thing is when we're asked this all the time, we have, an 80-year-old, my 80-year-old mother, it looks like, it looks like that side of the family, but she's never had cancer. She gets tested, she has a gene mutation, and then we have this, discussion about, whether to take ovaries out or not, right? And the key there is that the ovarian cancer risk is still very significant. We don't have good screening, but it all depends on, what their overall, what a woman's overall health is and all that kind of stuff. So we do know that there are these 80-year-old women with BRCA1 mutations out there that have never had cancer. And what we want to do is figure out why that is, and then, bring that all over and figure it out.
Yeah, and I think actually one of the things from the other cancer syndromes is it tends to be like one aspect will burn out, but the other one's still going.
Right.
And so that you have one cancer where they really get it at a younger age and another thing that really becomes a problem at older ages. And so I think that's true here, where some things you may be decreasing your risk of one, but your risk of the other, maybe it's hard to know.
Yeah, and as you're getting a sense of, there are multiple cancer syndromes. We're focused on one today, and we actually, we have a conference every Tuesday, at 1, where we bring in all these, other kinds of genetic syndromes to teach each other, because there's a lot that we can learn from the different hereditary cancer syndromes. All right, more questions. I know we're kind of, all right, so we're going to eat lunch, and then just as a reminder of what happens next, I have to actually remind myself what happens next here. So you're going to be eating lunch now, and then at 12:30, you go out to the concurrent sessions. It's in your